Hello everyone, welcome to my YouTube channel, Dr. Akif Baig. Today we will be talking about FRAIL AF randomized controlled trial. So as you all know, in patients of atrial fibrillation, nowadays we use novel oral anticoagulants and rather than vitamin K antagonist because there is no requirement of frequent monitoring of PT-INR. However, there is still some ambiguity whether frail patients, that is more than 75 years old patients with atrial fibrillation who are already taking vitamin K antagonist, whether they can be switched to NOACs or not. Otherwise, in patients who are new onset AF, NOACs is preferred over vitamin K antagonist. So this was a multi-center open label randomized controlled trial. Older patients with atrial fibrillation living with frailty that is more than 75 years of age plus a frailty indicator score of more than 3 were randomly assigned to switch from INR guided VKA treatment, that is vitamin K antagonist treatment, to an NOAC treatment or to continued vitamin K antagonist treatment. So what they did was they took patients, and half of the patients all the patients were already on vitamin K antagonist, that is either acetylrom or warfarin. Out of which half of the patient they transferred them into NOAC group, and the remaining continued vitamin K antagonist, and they followed up for 12 months and tried to see the outcomes. So inclusion criteria was any patient who is aged more than 75 years and who is currently being managed on INR guided vitamin K antagonist treatment for atrial fibrillation. Exclusion criteria: patients with a GFR less than 30 or with valvular atrial fibrillation were excluded from the study. So any patient who have valvular atrial fibrillation, that is patient with a mechanical valve or patients with mitral stenosis who is having AF, they were not, then guidelines itself says that NOACs are contraindicated or NOACs should not be used. So in those patients were excluded from the study. Also, patient with eGFR less than 30 was excluded because in those patients, NOACs cannot be used. So total of 2,621 patients were screened. After randomization, 1,330 patients were selected. Half of the patients were allocated to vitamin K antagonist group. So that means that they were asked to continue the vitamin K antagonist, and remaining half was allocated to the NOAC group. So follow-up was done for 12 months. So they tried to find the primary outcome, which was in the sense primary outcome was any major or clinically relevant non-major bleeding complication, whichever came first, accounting for death as a competing risk. And secondary outcome was thromboembolic events. So they assessed both the thromboembolic events in this patient and also the risk of bleeding in them. So baseline characteristics was mean age was around 83 in both the groups. Majority of patients were male with female of percentage of 41.4% and 36.2% here. And majority of patients was having permanent atrial fibrillation. And duration of atrial fibrillation in all these 12 patients, duration was of minimum of 12 years and 13 years if patient was continued with VKA. So Chadwick score was 4 in both of the groups, and history of major bleeding prior was present in 15% and 13% in each of the group. So results, so between January 2018 and June 2022, a total of 2,621 patients were screened and 1,330 patients were randomly assigned. The mean age was 83 years. Yes. So after 163 primary outcome events, the trial was stopped for futility according to a pre-specified futility analysis. So the primary outcomes, that was the major or clinically relevant non-major bleeding, was seen in the majority of patients who switched to NOACs from vitamin K antagonists, that is seen in 15.3% of patients, whereas it was seen in only 9.4% patients in patients who continued with vitamin K antagonist. However, when individually it was assessed, the major bleeding, clinically not relevant non-major bleeding, were also found to be higher in patient with the NOAC group when compared to vitamin K antagonist group. However, the risk of thromboembolism was found to be similar in both the groups. It's 2.4% and 2%. Also, all-cause mortality, composite of ischemic and hemorrhagic stroke, and composite of thromboembolic events plus major or CRNM bleeding were all very much similar in both the groups. So majority of patients who had the major bleeding or any clinical relevant non-major bleeding were majority of patients underwent GI bleeding in the NOVA group, that is 9 patients here and 1 patient only who continued with VKA. So brain bleeding was seen in 7 patients and 6 patients in VKA, which was similar in both the groups. And non-relevant, clinically relevant non-major bleeding was found to be skin bleeding was seen in 23 patients, oropharyngeal 19 patients, and 20 patients as urogenital bleeding. So coming to discussion, in this randomized control trial among FRAIL older patients with AF, switching INR-guided VKA management to a NOAC-based treatment strategy was associated with a 69% increase in major and CRNM bleeding complications. So, however, event rate for thromboembolic events, major bleeding in isolation, hemorrhagic stroke, or the composite of hemorrhagic and ischemic stroke were low in both the treatment arms, preventing us from drawing firm conclusions. So, FRAIL-AF pragmatic trial showed that switching INR-guided VKA treatment to a NOAC in FRAIL older patients with non-available AF is associated with more bleeding complications than continuing INR-guided VKA treatment. However, this trial was not powered to demonstrate differences in thromboembolic events, major bleeding in isolation, hemorrhagic stroke, or the composite of hemorrhagic and ischemic stroke. This trial indicates that careful consideration should be applied when choosing between continuing vitamin K antagonist or switching from a vitamin K antagonist to a NOAC in older patients living with frailty. Thank you.